Okay, I'm going to go ahead and get started. Good afternoon. It is an honor to be with you today. Thank you for joining us. I'm excited to talk to you about one of my favorite things, which is newborn screening. We're going to talk about what it is and why it matters. And if you have questions, you can put them in the chat, or you can always email me at lisa@patientadvocacystrategies.com. Today, we are going to talk about the mission of Patient Advocacy Strategies. I'm also going to mention how I became involved in newborn screening, what it is, and then what you can do in your own state to make newborn screening for any particular condition a reality. And then I'm going to highlight some resources that we have created at PAS to help educate and equip advocates. So at Patient Advocacy Strategies, we really strive to put the patient back at the heart of innovation, and that includes in advocacy, because without family advocates, we would not be able to make a lot of the progress that we've seen over the past, especially 20 or 30 years. So we are a consulting firm that can provide a suite of services to engage with and glean insight from patients and related disease community stakeholders. And ultimately, our goal is to, like I said, make sure that the patient is at the heart of everything. And so we build sustainable, proactive, and data-informed partnerships with patient communities through patient communication rooted in humanity, patient centricity, and understanding that supports the needs of treatment developers across all phases. A little tiny bit about me. I am the Director of Advocacy for Patient Advocacy Strategies. I have a bachelor's degree in political science and a master's in strategic communication, and I only mention that because that will come into play in my story. And I'm also an author of 2 books. One just came out about 6 weeks ago, and it's all about effective advocacy. So I'm very excited about getting that out into the world. My daughter, Victoria, is the reason that I have become an expert in certain areas of newborn screening advocacy in the United States. You can see her pictured here. The 2 pictures on the left were actually about a week before she became symptomatic with Krabbe disease. And we had no idea that anything was wrong with our beautiful, healthy baby. In fact, I remember remarking to my husband about 2 weeks after she was born that everything must have been fine from that test. Whatever that test was, that's what I said, because I couldn't remember, which is another reason why we need to improve education about newborn screening in the prenatal period in the United States, especially. I didn't know what it was, but nothing came back, so we thought it must be fine. But when our daughter, Victoria, was 5 months old, everything changed. In fact, it's the day after that picture of her in the black headband. It was like a light switch had been turned on, and our baby was not the same. She was incredibly irritable. She was very clearly in pain. She could not keep any milk down. We knew something was very, very wrong, but we never would have imagined that 6 weeks later we would find out that our 6-month-old daughter was dying, that she would not live to be 2 years old. But the worst part, and truly the root of my trauma, were the words that were spoken next when we pleaded with the neurologist for something, for anything that we could do, because we thought, it's 2015. What do you mean there's nothing we can do? And she said, if you had caught it at birth, you could have treated it. I will never forget those words. I will never forget the emotions that went through my mind, but I especially will never forget the anger that I felt when I found out if she had been born just 3 hours north in New York State, Tori would have been screened for Krabbe disease at birth, and we could have treated her. Instead, she did indeed pass away at 20 months of age in March of 2016, and that's when my advocacy began. It is because of Tori that I fought over the course of 5 years, a little more than 5 years, with 3 different legislative attempts to reform newborn screening in Pennsylvania. I did finally succeed, as you can see here with my picture with the governor and my family and the rest of the behind the scenes team that helped make that a reality. But in November of 2020, Act 133 of 2020 was signed by the governor, making our newborn screening program one of the strongest in the country to this day. It is because of Tori that I persisted in advocating to the Newborn Screening Advisory Board and convinced them to add Krabbe disease, making Pennsylvania the 9th state to begin screening for Krabbe. For reference, we just hit our 20th state last month, so it is a marathon. And it is because of Tori that in our first 7 months of screening, 4 babies in Pennsylvania were identified with infantile Krabbe disease, including identical twins who were born on her birthday. Since Tori gets the credit for all of this, I always start my presentations by highlighting her because I wouldn't be here if I had not gone through this experience. So let's dive in. What is newborn screening? I always love to start with this quote by the founder of newborn screening, Dr. Robert Guthrie, who said, "No child should die or suffer disabilities if a simple blood spot can prevent it." If it were not for Dr. Guthrie taking the pleas of parents and his own niece who had PKU into consideration, we would not have newborn screening as we know it. We may not have it as we know it today, but he's the one who figured out that he could use dried blood and detect conditions that needed immediate treatment. So we're so grateful for Dr. Guthrie. Newborn screening is a public health program. It is one of the most equitable things that we have in this country because it is available to every single baby born in the United States. It identifies an estimated 12,500 babies with rare treatable conditions in the US alone. Newborn screening happens 24 to 48 hours after birth, and it allows for timely intervention and treatment for these conditions that otherwise would be lifelong, create lifelong disability or even death, like with my daughter. And like I said, it began with one condition, which was PKU, and it continues to grow. Before we dive into specifics, I do want to highlight that newborn screening is not just a test, it is an entire system. It's very complex. It involves the scientists who develop the assays which allow us to identify these conditions to begin with, the lab technicians who run those assays and are able to screen for these conditions, the state newborn screening programs who not only manage all of like the notification of the parents, but they also have to determine which conditions should be on the panel. And then the clinicians and specialists who will ultimately see these patients and their families. There are actually also 3 tests that are part of newborn screening. It involves a dried blood spot test, which you can see a picture here of one of my twins. That's their dried blood spots. I made them do the newborn screening in the room. And a pulse oximetry screening, which looks for congenital heart conditions, and a hearing screen. The dried blood spot aspect of newborn screening takes place, as I said, 24 to 48 hours after birth. And the timing of that is extremely important because if the test is performed earlier or later than that, the results can be inaccurate, leading to false negatives or false positives. So the baby's heel is pricked and blood is put onto the filter paper, as you can see, and then those are then sent to the lab for analysis. But it's also important to point out that newborn screening is a screening test. It's not a diagnostic test. Every condition will involve confirmatory testing to confirm the diagnosis. For example, with Krabbe disease, which is what I'm the most familiar for, the lab first is looking for low levels of an enzyme that is known as GAL-C. That's the abbreviation, obviously. If the GAL-C levels in the initial screening are low, then they call it reflexing. They will reflex to second tier testing for high cytosine levels. Cytosine is a toxin that destroys the myelin throughout the body, and babies with Krabbe disease cannot produce enough of that GAL-C to get rid of the cytosine. And that's what causes the central nervous system and brain damage. So at the same time, they also begin sequencing to look for related gene mutations. And all of this happens within a week, ideally. It would be great if it were even quicker. With MLD, it's very similar. The first tier of the test is looking for elevated sulfatide levels. And then if that is found, then they reflex to sequencing and to looking for ARSA activity. So it's very complex, but it's also multi-tiered in order to prevent as few false positives as possible. Now, I'm sure you won't be surprised to hear this, but every state runs their program extremely differently. And this is part of what I've spent the past 11 years becoming an expert on so that I can help other people. Because not everybody needs to hyper focus on this like I have. I truly want to serve the communities, the different disease communities, because this is my daughter's legacy. So please let me know if you have any questions. But some states have their own in-state lab, which of course then requires state funding, and the legislature has to approve the funding, and that makes it complicated in and of itself. Others outsource to either another state or to a private lab. In the United States, the private lab is Revity. Every state has a different number of conditions on its panel. So I mentioned earlier that if Tori had been born in New York, we would be living an entirely different story. Instead, she was born in Pennsylvania. And one thing I should have mentioned too about the bill that I passed, it made screening in Pennsylvania equal from hospital to hospital, because as I sat in these meetings and I listened to what was going on here, I quickly observed that in Pennsylvania at the time, not every hospital was even screening for the same thing. So that was only making the death by zip code issue in rare disease worse. So we fixed that here, but it still is a problem, of course. Being born in a different state can lead to a completely different outcome. How the conditions are added to the state's panel differs, and we'll go into that in a little bit. And then, of course, the funding mechanisms. How do you pay for it? All of that is different. But one way that conditions are added is through newborn screening advisory boards. You may be surprised to learn that you don't actually need to use legislation or pass a law to add a condition in 48 states. They all have advisory boards. Like I said, well, 47 states. Arkansas doesn't have one anymore. So every state except for California, New York, and Arkansas has a newborn screening advisory board. But of course, the authority differs from state to state. Some of them have the direct power to add conditions, like Pennsylvania now. Others recommend to their state's Secretary of Health, which usually will take the advisory board's recommendation. But the important thing to remember is that every advisory board understands their specific state's system and needs. And that's why I'm very passionate about involving them in anything that you want to do when it comes to adding a condition. And I know it can be easy to assume that they are an adversary. Been there, because our advisory board was not open to adding Krabbe disease at first. But I learned to take every no as a data point and to put aside my anger and my grief and just realize they're looking at this scientifically. What do I need to show them? And so as publications came out, I kept sending them their way, and eventually they did come to see the benefit of screening for Krabbe disease. So I have all the information on the advisory boards and when they meet. So again, you can reach out for that. What is the Recommended Uniform Screening Panel, or the RUSP? This is something that most states do use as a guidance. And here's just a brief timeline of how it even came to be. So before 2003, the discrepancy between the number of conditions on state panels varied from 4, I believe that was in Louisiana, to like 40, 50 in other states. So there were so many disparities. And so they formed the ACHDNC, the Advisory Committee on Heritable Disorders in Newborns and Children, in 2003 to begin to solve that problem. At the same time, the American Academy of Medical Genetics and Genomics was working through an evidence-based process to determine a list of conditions that should be on this list of recommended screening. So the RUSP list was officially adopted and established in 2010 by the ACHDNC, and things were continuing along very slowly. And in 2024, I was actually one of the advocates, part of encouraging the committee to revise the process after our first experience with Krabbe disease being denied and seeing the issues that happened and that could be prevented. A whole coalition was trying to get them to improve the process, and they had actually started listening. And we were really encouraged until April of 2025, when the committee was disbanded as part of the DOGE cut process. And we still don't have a federal committee. So in the meantime, the ACMG has created a newborn screening collaborative that will begin an evidence-based process, I believe, this July. and they're going to try to fill that gap until we have something at the federal level again. So it has been a little bit of a roller coaster in the newborn screening advocacy community for the past year or so. But there are currently 40 core conditions on the RUSP. Core conditions means that's what they're looking for. And secondary conditions are conditions that can be seen by screening for those 40. So there are additional conditions as well. But it is important to note that this is a recommended panel. It's not required. So this map from newsteps.org, which is an incredible resource if you need data of any newborn screening kind, shows the status of who is screening for how many RUSP conditions. And until last month, Pennsylvania was the only one that was only missing one, but Illinois caught up. So you can see the variation. States like Alaska are missing 8 RUSP conditions. Other states are much further ahead. So there is still a wide variability depending on which state you happen to be born in. And this is exactly why the Every Life Foundation began working to pass legislation in these states to encourage them to automatically add conditions that are added to the recommended uniform screening panel. And as an advocate, I can tell you that I am a huge supporter of this because the evidence has already been reviewed and scrutinized and peer reviewed, and it's such a process to get a condition on the RUSP, and yet there are still, even today, states that don't trust that, and they want to do their own evidence reviews, which to me just wastes time. And as we all know, time equals myelin, muscle, and life when it comes to these rare diseases. So right now, you can see on here the states that meet the Every Life Foundation's criteria for RUSP alignment, which means that they will add them, and there has to be a time frame for addition included in their legislation, and most of these states have a 2 to 3 year timeline. But then I also included other states that have RUSP alignment-esque policies. Some of these are statutory, which means they're actually written like in their newborn screening statutes. Others, it's more just a loose thing. But as you can see, we still have a problem because it's still taking more than or around 10 years for a condition to be screened in all states. The ethics behind adding conditions to newborn screening panels are far more complicated than I would have assumed 11 years ago. So I just want to highlight, and I'm not going to read all this, but this is the Wilson and Youngner criteria that is still used to determine if something is eligible for newborn screening. But the essential things are, is there a test? Is there an assay? Is there a way to detect what, like I mentioned earlier, a missing enzyme or an increased toxin or something? Is there a way to test for it at a population level, in a public health manner? Is there an approved or effective treatment? That is key because this is public health and it's not consented. There has to be something parents can do with this information. You can't tell them, especially when they don't even realize that newborn screening had happened, like I didn't. You can't just tell them, oh, your child has this disease, there's nothing you can do. There's so many ethical discussions happening about all of this, even still. But essentially, there has to be a test, there has to be a treatment, and the overall benefits of screening need to outweigh the harm. So I mentioned earlier that the disparity between states can look extreme. But I also know, after 10 years of being in this, that the difference isn't as extreme as it looks. And for the past 3 years, I've actually been part of a group through the Association of Public Health Laboratories who are working to recommend different ways of counting conditions. And we're hoping to publish this year about that. But right now, there are some states like California who say that they screen for 80 conditions. There are other states that say they screen for 35. But in reality, it's more just how they count them. So remember earlier I said there are 40 core conditions on the RUSP. There are also 26 secondary conditions. So right there, that's 66. If you want to count each of them individually, that's 66 conditions. But there are also some states that will count different subsets of a condition. So like different onsets as separate conditions. And I'm honestly not sure how this started, if they just wanted to look better to say we screen for 80 things. It's not just California, which is my home state. There's a lot of states doing this. But like I said, we will hopefully have a more standardized way of counting and even naming conditions in the future. So just know that when you look at the state map, it's probably not as bad as it looks when it comes to what your state is screening for. And in terms of increasing screening, we also do have some exciting developments happening right now. There are several next-gen sequencing programs that are happening. These are studies that are consented, so parents definitely know they're happening because they're in addition to the newborn screening, dried blood spot testing. They can look for hundreds of genetic conditions that have treatments or interventions. So it actually is a really encouraging thing. But I will tell you that newborn screening experts, especially the chemists, they have stated very firmly that it can never fully replace biochemical newborn screening because there are some conditions that you can only really see those enzymes and toxins and things to diagnose properly. But it is really exciting that we have programs such as Guardian, Beginnings, Florida's Sunshine Genetics, and Beacons. And these are just the ones in the United States. There is one in the UK that I'm aware of, and probably some others. But it's really exciting to see that we might be able at birth to give parents those options that my family didn't have. So I kind of already talked about this, but we're going to dive into why states aren't screening for just everything. Why can't they just tell a parent that they have a condition? And I want to tell you that it's not always, like as I said before, that they're an adversary. It's not that they are against screening for something. It's very important to remember that the newborn screening system has hurdles and barriers, and those vary state by state. We're about to see the full impacts of the Medicaid cuts from HR 1 affecting these public health systems as well. And so it's just important to know that patience is a requirement, even though we all understand the stakes of newborn screening. But one reason that states can't just screen for everything you ask them to is that there are 12 states that use another state's lab, and you can see those listed here. The states in blue are the hub states, and the states underneath them send their samples to those states for screening. So for instance, if you live in New Mexico, your newborn screening, your child's newborn screening test will be sent to Oregon. So if Oregon is not screening for MLD or Krabbe or whatever the condition may be, New Mexico there's really nothing they can do about that. So it's just important to understand that element of this because it is an advantage to those sending states in terms of economics and finances, but it's also a disadvantage if they want to move ahead with a condition that their sending state is not yet screening for. And there are states, as I mentioned, that outsource everything to Revity, which is actually a huge advantage, and we do that here in Pennsylvania. So that has given us the ability to add conditions in 6 months. After the advisory board approves it, if Revity already has the capability to run the assay, we can add it in 6 months. And so that's a distinct advantage that we have. And it also like I said, it provides economic benefit to the state as well. However, if Revity has not yet developed an assay for a condition, we can't add it. So again, advantages and disadvantages to outsourcing. And as I mentioned earlier, some of it has to do actually with the newborn screening statutes and the legislative language itself. There are a few states whose language is interpreted so narrowly, like California and Arkansas, that they can only add RUSP conditions. There is no wiggle room. There's no nomination process. Like I mentioned, Arkansas actually 3 years ago they disbanded their advisory board because of this new law. So this is why it's incredibly important if you want to try to change statutes in your state that you talk to all the stakeholders involved. And I know that can be frustrating because we just want results. We just want to get it done. It took me 5 years and 3 different attempts, but I will tell you my third attempt was the strongest one because we listened to stakeholders we hadn't thought to listen to before. Make sure that there is input, that you fully understand the ramifications of what you're trying to do, because a lot of states have not done that, even just in the last 10 years of watching newborn screening legislation. It's also sometimes a lack of funding. That's something we improved here in Pennsylvania. And this is one of those things that came from those stakeholders. As of right now, insurance is required to pay for newborn screening. So the way we do it in Pennsylvania is that it's part of the birthing bundle that the hospital sends to either insurance or Medicaid. So we don't have to involve the legislature anymore. We don't have to hope that in the budget process, they will assign the appropriations needed to add a condition anymore. And that's one of my proudest achievements, because public health should never become political. And we obviously have seen the ramifications from that as well. So what can we do right now in this environment that we are in? There are actually things, even though I know it's been a lot. It's been a lot in the last year and a half or so, a lot of uncertainty, a lot of discouragement, because so much of the progress we had made has been rolled back or taken away. But I want you to know that there are things you can do, and we're going to talk about that. So if you're coming from the advocacy side, there are a few things that I would really recommend that you do. The first is just to learn as much as you can, and I'll go deeper into these in a second, but really know your disease, your state, and then of course your story. But by know your story, I mean know exactly what they want to hear. You need to learn and practice listening to understand, and I would dive into that as well. We have to collaborate and communicate across disease groups and even within them. We all have different skills and expertise, and we shouldn't be duplicating efforts. And this is something that I see over and over again. As we all know, time and resources and people are limited in rare disease. And so we would be so much better off if we would just work with each other. And shameless plug for my new book and the educational trainings that we're going to release this fall. But I genuinely believe that this book can help you become a more effective advocate, because it helped me. So the 3 pillars of effective newborn screening advocacy that I developed are know your disease, know your state, and know your story. So by know your disease, oops, sorry, the slide didn't progress. By know your disease, I mean, know the specifics that the newborn screening advisory board or decision makers are going to want to know. Is there an assay? Is there an approved treatment? If not, I would honestly not even go forward when it comes to trying to get them to add the condition. You have to go backwards. Find the scientists who can develop the assay. Find out if you have an assay, can it be what they call multiplexed with another condition? Which means, can you add it into the state's existing workflow, which reduces time, money, staffing, all of those things. Learn as much as you can about your disease, anything related to the disease itself, before you start, because it will help you make progress more quickly. The next step is to know your state. Understand how your state operates, who the decision makers are, who's on their newborn screening advisory board. And again, I have spreadsheet after spreadsheet with all of this, and I'm always happy to help. Do they have a nomination process where you can submit for them to consider your condition? And are there other issues that are preventing the addition of your condition that you can solve? So like I mentioned, in Pennsylvania, we had to go to the legislature. Not all hospitals were screening for the same things anyway. There were so many different little issues, and I quickly realized my impact could be so much greater for those to come, for other conditions along the way, if I focused on solving those problems. And so that's what I did. And like I said, now we have one of the strongest programs in the nation, and we are not perfect. We are constantly working on improving it, but I'm really proud of what we did. But in terms of knowing how your state works, let's look at a couple others. So I already mentioned California has no newborn screening advisory board. They actually used to rely on the ACHD&C for their advisory board. So now they really have none. They generally add conditions within 2 years of being added to the RUSP. I will say they are a little bit behind because they have not yet added Krabbe disease, and we're coming up on the 3-year mark for that. There is currently no advocacy pathway there. And that's one of the hardest things for me when I'm trying to mentor parents. Can't we just legislatively mandate the condition? Honestly, you just need to change their newborn screening statute, and I'm willing to help anybody do that. But if we could open up their language to allow them to do pilot studies, to add conditions, to create an advisory board and allow them to add conditions through a nomination process, can you imagine the impact? California is such a high birth rate state. The impact would be incredible. So if anybody listening wants to tackle that, please let me know because I think it needs to be done. Rhode Island is a great example of a state that does have RUSP alignment legislation, but it can't fully do what it wants because it relies on Massachusetts lab. So even if they wanted to add the current RUSP conditions, until Massachusetts is doing it, they can't. So they also have a limited advocacy pathway because the advisory board, yes, can add conditions, but if the lab can't do it, you still might wait a decade. So in those cases, I encourage the advocates from the sending states to go and try to influence the lab, the hub state that processes it. And I already talked about Pennsylvania and how awesome we are now. I'm just kidding. Okay, so the last thing is to know your story. And I know that may sound like the easiest part because we have lived this, but this is where my background in strategic communication has really helped me because we all, if you are coming into this like me, because of your great loss and your trauma and your experience of knowing how it feels to not be able to do anything, you do need a little guidance with creating your story because it's so easy to approach it with anger and with grief. But I want you to imagine being the decision maker and having somebody come to you and yell at you. And believe me, I have done this. That's why I'm cautionary tale. Yell at you, even though they may not have known that the problem even existed to begin with. They are going to be set up to feel more defensive, right? Instead of wanting to listen to you and wanting to collaborate. So instead, it's really important to frame our story in like a we want to help you way. Like, this is not just my story. I am not the only parent who has lost a child in Pennsylvania to a condition that could have been treated. So framing it as I want to help you because I know that advocacy has power that those boards do not. They can't lobby. The Department of Health can't interact with legislators at all. We can do what we want. So just understanding all of that and figuring out how to frame our story in the most impactful way is really important, but we also have to make it concise. So I always recommend that you have like an elevator pitch that might be a minute long, but you also can have a 3 to 5 minute version of your story. But if you start with the elevator pitch, that allows them to ask questions and then you could get more time to speak. But it's really important to not only know your story, but to know how to tell it. And while our stories are incredibly impactful, sometimes our stories are not enough by themselves, which I know you don't want to hear. Nobody wants to hear that. But I love these two quotes because I think it kind of pulls together this idea that without data, you're just another person with an opinion. If you are not coming to these scientists and these doctors with actual evidence and publications and things to support your view, they might write you off. But at the same time, as Brene Brown said, maybe stories are just data with a soul. So figuring out how to incorporate that data into your story only helps your cause. So remember that data gives you credibility and it helps you establish that these are facts. These are not just opinions, and we're not just coming out of our pain. We are coming because we know that this would make a difference. So if you are coming from the industry side, we're going to talk about this completely differently. I've seen this done well, and I've seen it be done not so well. It is key, and this comes from having experienced advisory boards in more than half of the states at this point. They are often hesitant to industry involvement, and I think you can probably see why. Industry is going to benefit from kids being treated by the treatments they have developed, and so it's just really important to let your advocates lead. You can help them with knowing the disease landscape and knowing the advocacy groups within it and bringing them to the table. Bring them to the table, but empower them. Don't overpower, don't take over, because that only creates issues. It creates distrust, not only amongst the advocates, but amongst the states as well. And like I said, remember, this is their This is our, as advocates, our table, our legacy. We belong here. This is what we are trying to do to change the world, to make it better because of our suffering. So just please always remember that. It's also incredibly important to listen to understand us. Don't assume that you know the lived experience of patients and caregivers. Truly listen to them, and along those lines, know their stories and allow the advocates to be the ones to share them at every possible opportunity. I really think that at these newborn screening advisory board meetings, it needs to be parents and scientists and not industry presenting, simply because of the perceived conflicts of interest and things like that. But also it comes across so much more powerfully when it's a parent. But of course, we want to collaborate and communicate with our industry partners. Use your resources to assist in the implementation. But I also really want to emphasize that, as I said before, we need to use legislative mandates sparingly. Don't just use it to add a condition unless you are increasing funding to the lab and the newborn screening program and working with those two entities to craft the language. Don't create long-term problems with seemingly quick solutions. And then again, remember that the perception of industry is mixed among decision makers. So what can we do right now as parent advocates, as industry partners in this environment of so much uncertainty? We can attend newborn screening advisory board meetings. A lot of them are virtual, which is how I have attended so many, especially in the last couple of months. We can build relationships and coalitions with these state programs. And in that, we always need to be kind. It's okay to be firm and blunt, but just remember that you want these decision makers on your team, right? You don't want to ostracize them or make you feel like you are a pain that they don't want to deal with. You want them to smile when you come in the room because they know that you're on their side. So build those relationships with anybody that you can. That can even be your state representatives and senators and their staffers, because the staff does all the work. It can be the newborn screening director. Like I said, ask them, what hurdles are you facing? What can I do to help you? So also find other rare disease groups in your state and talk to them as well. You can create one pagers or other resources, and I'm going to share a couple of those at the end briefly that we've created that you're welcome to use. Create things that you can be sending along, even if you only have time to sit at your computer and send some emails. That is what matters, is that you're doing something with the time that you have. Look at what has already been done in your state historically. That can take a little more digging, but this is where those coalitions come in handy. And especially if your state has a rare disease advisory council, just start these discussions. One of the concepts I discuss in my new book is linking. So you have a conversation with somebody. They may not be the right person for that conversation, but they can likely link you to another person who would know. And so just building those links in your chain can lead to success more quickly. And again, examine the playing field. Who is already doing something in your state? Don't start all over. Don't duplicate efforts, because it just makes all of our lives harder, right? Like if we find out that somebody has already made the progress we were hoping to make, we just wasted time. So make sure that you are evaluating the entire playing field. In everything that we do, we must communicate and operate transparently, constructively, collaboratively, and ethically. It is so very important that we maintain our integrity and our credibility, especially as parent advocates in this space. Because if they find out that we have been giving them misinformation, they aren't going to listen to us anymore. So we also don't want to blindside the public health labs. Again, with legislative mandate, I have seen some poorly written laws completely undermine what the lab was already working on. And they had to stop and they had to move to this next thing, but they weren't given additional money to do it or additional staff. And so it just creates a burden on people who are already very, very overworked and under-resourced. So yeah, talk to your state newborn screening programs. You can find that information on Baby's First Test or by Googling your state and newborn screening. And in my experience, the staff of newborn screening programs and advisory boards are just as passionate about newborn screening as we are. And so it's so important to approach these conversations with that mindset of we're on the same team, and to figure out, is there something we can do to help the state? But we also need to make sure we are listening to understand in everything, because if we want them to support us, we have to listen to them. So I love this definition of listening to understand. It requires humility, a willingness to be wrong, and the ability to change one's mind when new information is obtained. It humanizes those on the other side and helps better understand the motivations behind their stance. So much like I said earlier, you have to take what they say as data. If they say, no, we can't add your conditions right now, ask another question. What would it take? What is keeping you from being able to add this condition? Just truly listen. And honestly, I don't just mean this as a passive thing. This is where you find your strategy, because truly, I can tell you that the changes we made in Pennsylvania only happened because I listened to understand. Um, Listening to understand doesn't obligate you to agree, but it helps you understand their perception, their perspective, and it will help you get results. So just remember, underlying issues in the state may need to be addressed to strengthen your newborn screening system. And it honestly takes all of us to have this approach, especially parents who come into this with added grief and emotion. Um, Honor and respect the expertise and experience that everybody brings to the table. That is so important. We all know how it feels to be just pushed aside because we're just a parent, or or because we're in industry, or whatever the case may be. So we need to make sure that we are giving that same respect to others. And as I said, be willing to collaborate. And one of those collaborators could be with us. At PAS, we bring more than 10 years of experience in newborn screening expansion. I know the system inside and out. I've now worked alongside 3 different disease groups, and we'll be soon working with a 4th to help guide them through what do you do, because 50 states is a little bit daunting. And so I'm able to help customize those plans for expansion and guide them and help it feel less overwhelming. And I want to help you as well. Um, and as I mentioned, that we're going to be having comprehensive training modules about effective advocacy. And this applies to everybody, not just advocacy in industry, honestly, anybody who feels like it doesn't have to be this way, whatever your it may be. In this case, newborn screening. Newborn screening shouldn't be this disparate, it shouldn't be this different from state to state. It shouldn't be this difficult and this expensive to get the funding that we need to save these babies' lives. So we are opening up the Brighter Blueprint Studio in the fall, and I'm really excited because these 12 threads of effective advocacy have been hard earned. These lessons have been hard earned by me over the past 10 plus years. And so, as I said, shameless plug for my new book. We do have a couple of 1-pagers that, well, 2-pagers, I guess, that we've created that I will also send out in an email. But one is this newborn screening at a glance PDF that just breaks down a lot of what I said into a really simple little sheet that you can hand to stakeholders or anybody that you want to teach about newborn screening. And the other thing that I have created is something that I gave out to every state newborn screening program that I could at a conference last fall about improving the condition nomination process with advisory boards, but also making that process transparent on state websites. So this is my little side project, especially as I've now observed so many different advisory boards that really should be collaborating and learning from each other. I want to help them. So I just want to close with pointing out that we all have the same spark, and that's saving the lives of these children with rare, serious, or fatal conditions. And so with that, we have a shared responsibility. Families began the movement of newborn screening. If it were not for parents who were determined, we wouldn't have it at all. And now a dedicated ecosystem sustains it. So thank you to the newborn screening programs and the labs who are on the front line of detecting these disorders, to scientists in industry who are innovative and they're constantly looking for new ways that we can help these patients. And of course, for advocates, because we are the heart of the entire mission. We all have a role to play in ensuring that the legacy of these children continues to save lives. And I'm really grateful for your willingness. So if you would like to pursue change in your state, please let us know. We are ready to help you, and I can't wait to hear your story. So with that, I will close. If we have any questions, you can put them in the chat. It does look like we have one. Okay. When is the appropriate time for a biopharma company with a clinical program, which is assumed to be approved in the future, to treat a condition that may be identified by newborn screening, to engage in newborn screening advocacy with patient communities and advocacy groups? Do they start before it's available or await approval? And if it's inappropriate for them to engage in the process directly when led by the advocacy groups, how can you help companies that have newborn screening as a policy initiative in anticipation of a commercial launch? Okay, so there's a lot there, but let's break that down. So when should biopharma companies begin engaging with advocacy? I would say in phase 3 of your clinical trial. If the data readouts are good and it seems like this is going to be a thing, one of the big ways that you can support these communities is, again, to let them lead, but find out what they need. Is there an assay available, or does one need to be developed? Because that can take a long time, and that can be done in parallel with your clinical trial. So be looking at the diagnostics so that the advocacy groups have something that they can be advocating for. But I do believe that it is important that the engagement between advocacy and industry begin before approval, because on the day, on your PDUFA date, these groups can begin nominating this condition to states. The other thing that you might need to do is participate in a program like Screen Plus. I also believe some of these genetic sequencing programs are allowing for clinical trials, like to get your gene on their list, but you would want to verify that. So in that case, you need to be figuring out, what does it take to get our gene on Guardian or Beacons or these other studies while it's still in clinical trial phase. Basically, any data that you can give to the advocacy groups is going to be huge before you actually launch and have a commercial product. So that's something that I would absolutely love to help your company do, because I do come from the advocacy side. I know how both operate, and I would love to be that go-between in helping create a pathway and a strategy. So thank you so much for joining us today. I hope this was informative, and we will put this up on YouTube for future reference. But I hope you are leaving with a sense of empowerment, that there is something that you can be doing right now, but also just a greater appreciation for the complexity of all of this. While it seems like it should be so simple to just add a test and screen for it, I hope you now understand why it's a little bit more complicated than we would all like for it to be. So thank you so much.